Good morning, everyone. Thank you for joining us today. We'll be presenting on this CME on hyponatremia with Anson Chua today, and our supervisor will be Dr. T. Let's start our presentation.
Hi, good morning, everyone. So for the introductions for hyponatremia, firstly, hyponatremia is defined as serum sodium concentration less than 135 millimole per liter. And hyponatremia is the most common disorder of body fluid and electrolyte imbalance encountered in clinical practice. Next, hyponatremia is primarily a disorder of water balance with a relative excess of body water compared to total body sodium and potassium content. It is usually associated with disturbance in the hormone that governs water balance, that being vasopressin. Hyponatremia also reflects a low effective osmolality or hypotonicity, which causes symptoms of cellular edema. However, it may also occur with isotonic or hypertonic serum if the serum contains many additional osmoles. Next will be the clinical features of hyponatremia. Symptoms may vary from mild to severe. Severe symptoms are caused mainly by brain edema and of increased intracranial pressure. Moderately severe, there will be symptoms such as nausea without vomiting, confusion, and headache. Severe symptoms will be like vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, and coma. Mild symptoms will be like gait disturbances, falls, concentration, and cognitive deficits. Next will be the classifications of hyponatremia. There will be in non-hypotonic hyponatremia, it's divided into isotonic and hypertonic hyponatremia. This is based on the European guideline of hyponatremia CME. For the isotonic hyponatremia, serum containing additional osmoles that increases effective osmolality and reduces the serum concentration by extracting water from the intracellular compartment. Examples of it will be like glucose, mannitol, and glycine. Next, for hypertonic hyponatremia, it's mostly hyperglycemia-induced hyponatremia caused by dilution due to hyperosmolality. For hypotonic hyponatremia with decreased extracellular fluid volume, it is depletion of circulating volume with or without deficit of total body sodium, able to increase vasopressin release despite hypotonicity. Non-renal sodium causes is gastrointestinal losses and transdermal losses. Renal sodium losses will be diuretics, primary adrenal insufficiency, cerebral salt wasting, and for kidney diseases. For diuretics, it's more so with thiazide as compared to loop diuretics, as thiazide is assumed to directly induce release of vasopressin or increase the response of vasopressin to vasopressin. Loop diuretics rarely cause hyponatremia as they reduce osmolality in the renal medulla and thus limit the kidney's ability to concentrate urine. For cerebral salt wasting, it's a condition where renal sodium loss in patients with intracranial disorders occur, such as in subarachnoid bleeding. Next, for hypotonic hyponatremia with normal extracellular fluid volume, euvolemic hyponatremia is caused by an increase in body water, which results from an excessive fluid intake in the presence of an impaired free water excretion, either due to inappropriate vasopressin release or due to low volume of solutes. The examples being SIADH, syndrome of inappropriate antidiuretic hormone, secondary adrenal insufficiency, and hypothyroidism. For syndrome of an inappropriate antidiuretic hormone, it causes progressive hyponatremia until the expression of vasopressin and aquaporin water channels are downregulated, a process called as vasopressin escape. Urine osmolality will usually be more than 100 milliosmol per liter, and it's mainly a diagnosis of exclusion. For secondary adrenal insufficiency, it's caused by absent or reduced secretion of ACTH, causing hypocortisolism. In normal circumstances, cortisol normally suppresses vasopressin release from hypothalamus. In hypothyroidism, however, there will be high water and low solute activity, which will cause absent in vasopressin activity. The serum sodium concentration decreased by around 0.14 millimole per liter for every 10 milliunit liter rise in TSH seen, indicating that only severe cases of hypothyroidism will result in clinically significant hyponatremia. Next will be a hypotonic hyponatremia with increased extracellular fluid volume. In kidney disease, there will be decrease in GFR, which will decrease in free water excretion. In heart failure, there will be impaired cardiac output, which will reduce the effective circulating volume, which will stimulate the baroreceptor and increase secretion of vasopressin. Liver failure, there will be systemic vasodilation and AV shunting of blood, which will reduce effective arterial blood volume, which will stimulate vasopressin through the baroreceptor activation. And lastly, for nephrotic syndrome, there will be low oncotic pressure, which will stimulate vasopressin secretion. This is another type of classification for hyponatremia. Firstly, based on biochemical severity, mild will be from between 130 to 135 millimole per liter, moderate being 125 to 129, and profound less than 125 millimole per liter. If it's based on time of the development, acute being less than 48 hours, chronic at least 48 hours, or if the duration is unknown for us. Next, drugs which are conditions associated with acute hyponatremia, this such as post-operative phase, post-resection of the prostate, post-resection of endoscopic uterine surgery, polydipsia, exercise, recent thiazide prescription, MDMA, colonoscopic preparation, and others. Based on symptom severity, as I said, there will be divided into moderately severe and severe. I mean, it is based on serum osmolality. Hypotonic hyponatremia is normally when the serum osmolality is less than 0.5 milliosmol per kg. Next, we accept hypotonic hyponatremia as a cause of without evidence for causes of non-hypotonic hyponatremia. So these are a few causes of it. Examples such as glucose, mannitol, glycine, histidine tryptophan ketoglutarate, maltose, urea alcohol, ethylene glycol, triglyceride, and IVIG and monoclonal gammatoprotease. These are the parameters for differentiating causes of hyponatremia. Firstly, if there is hyponatremia, we determine whether it's acute or severe symptoms. Then next, we will see whether the urine osmolality for the patient. If it is less than 100 millimosmol per kg, we can consider primary polydipsia, low solute intake or pure photomania. If it's more than 100, next we will see the urine sodium concentration, where if it's less than 30, we can say that it's mostly due to low effective arterial blood volume. And if it's more than 30, we can use a diuretic or either kidney disease, which will be the cause of it. Next will be the treatments for hypotonic hyponatremia. These are a few questions you need to ask in this algorithm. Firstly, is the symptom severe? Or is the symptom moderately severe? Is it an episode of acute hyponatremia? Next, is it reduced circulating volume? Or is it an expanded extracellular fluid volume? So for hyponatremia with severe symptoms, based on this guideline we used, it's mainly IVI 3% hypotonic saline, 150 ml over 20 minutes. Then you repeat the sodium level while repeating another infusion for the next 20 minutes. You may repeat the above steps twice or until the target of 5 millimole per liter increase in sodium is seen. If there is an improvement of symptoms after sodium increase of 5, you can stop the infusion and give IVI 0.9% saline until cause-specific treatment is initiated. At the same time, you have to limit sodium increase to 10 millimole per liter for the first day, then 8 millimole per liter for subsequent days. So there will be a total of 80 millimoles per liter in 48 hours. If there is a improvement, if there is no improvement of symptoms, sodium increase of 5 millimoles. The second one is no improvement. You may continue IVI 3% hypertonic saline and aim for at least 1 millimole per liter increase per hour. Then, as previously, you can stop the IVI when symptoms improve. Sodium increases by more than 10, or sodium reaches at least 130 millimole per liter. This is a formula to estimate the change in serum sodium, which you can see. So the formula is as such. The top formula is for, it's predicted. The top formula is the Androgew-Medias formula, where there's a change in serum can be expected when you infuse sodium, infuse of the sodium minus your serum sodium over your total body water plus 1. Then an estimated, you can either estimate also where you can estimate by 1 cc per kg of 3% saline increases sodium concentration by around 1 millimole per liter. And 3 cc per kg of dextrose 5% decreases sodium concentration by 1 millimole per liter. So for acute hyponatremia without severe and moderate symptoms, make sure it's not a spurious results. Stop the fluids, medications, and other factors that may contribute to hyponatremia. And if the sodium persists, you can decrease the sodium by more than by IVI 3% hypertonic saline ml over 20 minutes. For chronic hyponatremia without severe or moderately serious symptoms, you can stop the fluids, medications, and other factors that may contribute to hyponatremia. In mild hyponatremia, not for treatment with sole aim to only increase the sodium concentration. In moderate or profound hyponatremia, it's advised to check the sodium at least every 6 hours until serum sodium concentration has stabilized. For cause-specific treatment, in expanded extracellular fluid, it's mainly by fluid restriction. And in reduced circulating volume, you can try IVI 0.9% normal saline at a rate of 0.5 to 1 milliliter per kg per hour. In cases of hemodynamic instability, the need for rapid fluid resuscitation overrides risk of overly rapid increase in serum sodium concentration. And a sudden increase in urine output to more than 100 milliliter per hour signals an increased risk of overly rapid rise in serum sodium concentration. So you should monitor more rapidly the sodium concentration. Next is an article by Garahi and friends regarding continuous versus bolus infusion of hypertonic saline, where you can see that bolus administration is recommended to replace slow intravenous infusions. This is as bolus intravenous injections is able to deliver a faster elevation in serum sodium concentration with more effective restoration of GCS within 6 hours of presentation, as compared to the continuous infusion of hypertonic saline. In this article, the use of dextrose and DDAVP to prevent overcorrection was more often required after bolus therapy as compared to continuous infusions. Next, for overcorrection of hyponatremia, firstly is to discontinue ongoing active treatment, and the regime to use to lower serum sodium concentration is of IVI dextrose 5 water, 6 ml per kg body weight, infused over 2 hours, which will lower your sodium concentration by around 2 millimole per liter. Other than that, you can also give IV or subcut desmopressin, 2 mcg per QID or TDS, and the dose will be continued even after dextrose 5 water is stopped to prevent the rise of serum sodium due to excretion of the dilute urine. When in overcorrection of hyponatremia, your serum sodium should be measured around every 2 hourly, and serum sodium lowered at average of around 1 millimole per liter per hour. This is an algorithm based on another guideline by the European Nephrology Society. For the hyponatremia moderate severe, the correction on how you should do it in acute settings. In moderate symptoms, you should use hypertonic saline solution of 0.5 milliliter per kg per hour. In severe symptoms, you should use around 1 to 2 milliliter per kg per hour or a bolus of 100 milliliter. Then you can try to evaluate 2 hours later. If there's an increase in serum sodium of more than 6, you can stop the hypotonic saline infusion. If there's a serum increase of less than 1, you can try to increase the infusion rate to 50 to 100%. If there's a serum sodium increase of between 1 to 6 millimole per liter, you can maintain the infusion rate and evaluate after 2 hours later. Then you should, when you monitor back the serum sodium, if it's less than 120 millimole per liter, or there's an increase of less than 2 from the start, you should go back to the starting of the algorithm and treat as severe symptoms. If there's moderate symptoms, you should consider maintaining infusion rate and evaluating 4 to 6 hours later. If there's a serum sodium concentration of between 120 to 130, you can stop the hypotonic saline infusion. The next will be presented by Michelle.
Okay, so I'll go through regarding the most common causes of hyponatremia for inpatient, which includes thiazide-induced hyponatremia, DIH, and also SIADH. The commonly used thiazide in our hospital includes hydrochlorothiazide, and it acts by inhibiting the reabsorption of sodium and chloride from the distal convoluted tubule by blocking the thiazide-sensitive sodium chloride channel. The risk factors, the patients at risk of developing hyponatremia includes old age, women with reduced body mass, and also concurrent use of other medications that impair water excretion. So hyponatremia can occur within 2 weeks of starting the diuretic, but it can occur at any time during the thiazide therapy when subsequent contributory factors are complicated, such as reduction of renal function with aging or ingestion of other drugs that affect free water clearance or changes in water or sodium intake. Some of the patients might appear to be hypovolemic for thiazide-induced hyponatremia, but mostly they appear to be euvolemic. The pathophysiology mechanism underlying the DIH are still unclear. However, there are 3 main factors that are implicated in DIH. The first one is increased water intake. Thiazides might cause polydipsia when combined with renal effects result in expansion of the total body water and development of hyponatremia. It will also cause renal sodium or potassium loss, which is why the importance of potassium repletion in thiazide diuretics. It also reduces free water clearance, and it reduces the renal capacity to excrete free water, which is usually age-related. And the thiazide-induced volume depletion will stimulate the release of vasopressin. Otherwise, ingestion of other drugs can also impair the free water clearance, and this is why the reduce in free water clearance can explain why many patients with DIH behave as if their volume expanded, whereby the blood investigation will be similar to those with SIADH, which is initial volume expansion. So there are a few drugs that can increase the likelihood of DIH. NSAIDs, through the prostaglandin inhibition, can decrease free water clearance. Drugs such as clopropamide and SSRI may be associated with SIADH, and polydipsia caused by psychotropic medications can also predispose to DIH. For management of DIH, first thing, we need to discontinue the thiazide first. Next, we need to determine the volume status for the patients with DIH. If it is hypovolemic, normal saline infusion is appropriate because it will restore the volume and suppress the vasopressin release. For patients with euvolemia or hypervolemia, hypertonic saline will predictably raise the serum sodium concentration and is preferable. Administration of furosemide in addition to hypertonic saline can increase the free water clearance and thus hasten the increase of the serum sodium concentration while avoiding volume overload. In asymptomatic or minimally symptomatic patients, stopping the offending diuretics and restrict water to less than 1 liter per day usually all that is needed. And also need to increase the oral salt intake. Based on there's an article on the thiazide-induced hyponatremia. So based on this article, some of the prevention that they use in susceptible patients, including measuring the serum sodium within 1 day after starting thiazide diuretics. If the serum sodium falls, then the diuretic should be stopped. If there's little or no change in the serum sodium, it should be rechecked every 1 to 2 days later to ensure the stable level. Also, low dose of thiazide diuretic should be started instead. Then need to educate the patients on the danger of drinking excessive water. However, this is not usually practiced in our center. For SIADH, SIADH is the most frequent cause of hyponatremia in a hospital setting. So the lowering of plasma osmolarity does not inhibit the AVP, the ADH secretion as expected, and the free water is inappropriately reabsorbed at the level of the collecting duct of the nephron, thus inducing further hemodilution and hyponatremia concomitantly with the inappropriately elevated urine osmolarity. SIADH is a euvolemic hyponatremia, so need to rule out other low effective circulating volume with a normal CVP, absence of orthostatic hypotension, ascites, and edema. Need to rule out any diuretic therapy, rule out adrenal and renal failure and severe hypothyroidism, and any physiologic stimuli of the ADH secretion, including post-surgery and pain. So the other criteria includes serum sodium must be less than 135, the plasma osmolarity less than 275 milliosmol per kilo, urine osmol more than 100, and urine sodium more than 40 when the sodium intake is adequate. This definition is based on the nephrologia guideline. So this is another definition by the American Journal of Medicine. Mostly the essential criteria are mostly similar. So for the causes for SIADH, we need to find the underlying causes when SIADH is confirmed, because mostly they are caused by other things. So first one includes malignancy. So need to rule out look for any lung malignancy or GI malignancy or urogenital malignancy. So pulmonary disorders such as infection, tuberculosis, asthma, cystic fibrosis, and respiratory failure associated with positive pressure can also cause SIADH. Disorders of the nervous system also can cause SIADH, like commonly infections such as meningoencephalitis. Also ICB, stroke, brain tumor, head trauma, and hydrocaph and GBS can also cause this SIADH. And a lot of drugs can cause SIADH. For example, like SSRI, tricyclic, any sodium valproate, lamotrigine, and antipsychotics and anti-cancers. Other causes that is less common include like nausea, pain, or stress, or exercise related, and also general anesthesia. So we'll focus on the non-acute management of SIADH. So the aim is to achieve eunatremia in patients with SIADH induced mild or moderate hyponatremia, which is not posing as a medical emergency. First, we need to correct the hypokalemia, because by correcting the hypokalemia, it can also increase the serum sodium. So we need to give potassium chloride supplements if the patient is hypokalemic. Next, we need to ensure solute administration, where it can that will stimulate the induction of increased renal obligatory water clearance. So need to ensure adequate oral salt intake, because usually the hospital diet won't have enough salt intake. So we need to supplement with sodium chloride with minimum total salt intake of 5 to 8 grams per day. Another option will be oral urea, 15 gram BD, which is usually a therapy of choice in children. However, it is low palatability. So the next most important step is fluid restrict. So fluid restriction mainly it's based on the first formula, is useful to predict which patient will respond adequately. So the verse formula is calculated by dividing the sum of the urine sodium and potassium by the serum sodium. So if the verse ratio is less than 0.5, the patient might most likely will respond to fluid restriction less than 1 liter per day. If it is 0.5 to less than 1, we restrict the fluid to less than 500 cc per day. If the first ratio is more than 1, most likely the patient will not respond to fluid restriction. And restriction of fluid like 500 cc per day is used to prevent the worsening of hyponatremia only, but not correcting it. There's also a multinational registry found that the fluid restriction resulted in median increase of 2 during the first 24 hours. The response of the specific patient to fluid restriction is usually not constant and can vary from one day to another. Therefore, for correct use of the first formula, the electrolytes must be measured in serum and urine frequently. So for furosemide therapy, it is suitable for short-term therapy for SIADH hyponatremia. It will be effective if the urine's osmolarity is more than twice of the plasma osmolarity, which typically means a urine osmolarity above 500 milliosmol per kilo. Any sodium losses must be compensated by sufficient oral salt intake, and it will be particularly helpful in patients in whom SIADH will presumably be of limited duration, such as in days. For example, in a pneumonia patient or any causative medications after stopping the causative medications. It will be useful if the serum sodium is less than 120 with patients presenting with mild or moderate symptoms. If the serum sodium is more than 115 and it is patient is at low risk of herniation, such as elderly. Another choice of treatment will be tolvaptan. Although it is not available in our center, it is a very useful alternative for SIADH patient. It is a selective vasopressin receptor inhibitor. The mode of action, it will block the vasopressin, the ADH responsive vasopressin collecting duct receptor that ultimately induce the apical expression of aquaporin 2 channels through which the water is reabsorbed following the FVP stimulus. So it will reduce the water reabsorption and produce aquaresis without sodium loss, thus increasing the free water clearance and correcting the dilutional hyponatremia. The main indication is for patients which is not suitable for fluid restriction of furosemide or patient requiring longer treatment, for example, in chronic SIADH patient. The dosage is like 15 mg per day and maximum can be titrated up to 60 mg per day. It must always be initiated while the patient is hospitalized because the maximum aquaresis is on the day 1. So we need to monitor carefully the fluid intake for the patient. It is used as the monotherapy for SIADH and never be administered jointly with hypertonic saline, never be administered to any hypovolemic patient. So this is why the diagnosis of SIADH must be confirmed first before starting tolvaptan. This is a brief diagram that shows the patients for SIADH patient with mild or moderate symptoms. So based on the VERSE formula, we restrict the fluid, and depends on the response, we will decide on whether fluid restriction should be continued or not. And then if the patient, the VERSE formula is more than 1, the ratio or the fluid restriction is not feasible, then we start on the tolvaptan. So this is a brief algorithm whereby how to titrate the tolvaptan. So next, this is a table that can predict like probable duration of SIADH treatment as indicated by the etiology. So based on different etiology, they predict like how long the SIADH will last. So if it is, for example, mostly it will depend on the etiology. And for example, if there's a tumor, then or any medication causes, then it will be depending on whether like if you still continue the usage of the medication, most likely the SIADH will still continue. So for stroke or SAH, it will have like 1 to 4 weeks duration of SIADH. This is a brief, and we'll just introduce a bit on the reset osmotet, whereby this hyponatremia due to downward resetting of osmotet is one form of the SIADH. So in normal individuals, so you can look at the diagram here. In normal individual, the plasma ADH level are very low when the plasma osmolarity is below 280 milliosmol per kilo, thereby permitting the excretion of the ingested water, and this will increase progressively as the plasma osmolarity rise above 280. So ADH will increase when the plasma osmolarity rises, so increased thirst, so you will take in more water. But the downward resetting of osmotet can also occur in hypovolemic state, in quadriplegic patients, psychosis, tuberculosis, and chronic malnutrition, and some in normal pregnancy, whereby the serum sodium will fall approximately by 5. It should be suspected in any patient with apparent SIADH who has mild hyponatremia, usually between 125 and 135, that is stable over many days despite variation in sodium and water intake. So if you suspect like in any patient that you confirm like SIADH, but then you cannot treat with any sodium or water intake, and fluid restriction also not working, then we can confirm with a water load test. So this water load test is like you give 10 to 15 ml of kilo of water given orally or intravenously. For normal subjects or those with reset osmotet, they should excrete more than 80% of the water load within 4 hours. So SIADH patient excretion will be impaired. So for this reset osmotet patients, the identification is important because all of the non-acute treatment for SIADH may not apply, and the attempts are unnecessary and likely to be ineffective because it already like the body already reset itself, so it requires actually no treatment. The treatment should be aimed at the underlying disease. For example, if TB is the one causing it, then we can just treat the TB. So this is our references. Thank you for your attention. Any question?
Hi, T here. Just I saw Eng asking some question in the chat. So basically, just for your question. Okay, definitely for number one, strict IO is very, very important in case of hyponatremia, especially severe hyponatremia, because as mentioned previously, anytime when there's a polyuria or more than 100 ml per hour urine output, then there's a risk of overcorrection. This especially in the case of, like, for example, patient in psychogenic polydipsia who came in, suddenly they don't have access to extra water, then they pour out the urine, the sodium will increase rapidly. And the other one is like even certain other patient like SIDH, hypovolemia patient, when their cause of hyponatremia is removed, there's a risk of reduce in the ADS secretion and then suddenly excrete all extra free water. So this also will cause the rapidly increase in urine output and rapidly increase serum sodium. So this is definitely a thing to watch out, but in which we are not really doing properly, especially in an emergency department. So we must order for the strict IO for this patient with severe hyponet lah. And then for certain, okay, this guideline of how much free to give, all those things is actually there's a lot of different guideline with a different regime and different rate. You can always adjust the rate according to patient. If a patient cannot tolerate fluid, you can even give lower fluid and also minirin earlier. If you cannot, for the overcorrection, you want to give D5 to bring down the overcorrection, but you worry about the volume status. This is the case that you can just give minirin alone also. And for patients severe hyponet in AKI and CKD setting, this is actually quite difficult to manage. Usually, because when they already have a kidney impairment, there will be a bit of impairment in the salt and the water excretion at the kidney level. So we cannot predict the response to our normal regime. So the best thing is actually have to consult nephro. Sometimes they can use a different solute concentration inside their dialysate to control the change in the serum sodium level. I think this is answering to your questions. And actually just back to, can you go to the slide of the severe management? This is just to add on. Yep. There's many different guidelines for this, but currently we prefer to use bolus rather than infusion. So bolus, you either can follow this guideline or even other certain guidelines, they're using 100 ml 3% saline over 10 minutes and repeat. And this, while waiting a result, the left-hand side, I think you type wrongly, they stop the infusion. The normal saline until cause-specific treatment is initiated. Actually, what that means is KVO is a lowest volume possible. So usually we just stop the infusion, don't give any drip because we worry risk of overcorrection. And usually, because I think there's few cases of overcorrection sodium happened here before with osmotic demyelinating symptoms after that. So we are quite a bit cautious in 3% saline use. And if you are using, so preferably have to make sure you trace the sodium urgently so that in case of overcorrection, we can correct it in time. I think this is the thing that I just want to highlight, and just always watch out of those patients at high risk of overcorrection. As I said previously, your psychogenic polydipsia patient, because there's suddenly they have less of access to the water. Those patients with a hypo K, those patients with the other patient is those hypopituitary patient with they have concurrent hypocortisolism and diabetes insipidus. Sometimes when you treat the hypocortisolism, suddenly there will be increased free water excretion and the sodium can go out very fast. So these are patients that we have to watch out, and especially other patients that high risk for ODS includes those with very severe hyponet, less than 100, those elderly, malnutrition. These are patients that we have to watch out for. Any other question?
Okay. Fasrin type in the chat box that if lab reported the sodium value of less than 100, you can call the lab to get the exact sodium value. Thank you, Fasrin. Any more question? If there's no more question, then I think we'll end our session here. All right, thank you everyone. Thank you, Dr. T. So that's the end of our presentation today.